listening on GBM's Facebook Live page.
Yeah, I'm Mary Beth Marsden.
I'm Don Scott, and our first guest today, Rachel Ridgely. I've been sitting here since you sat down going, where do I know this woman from? And I keep looking at you saying, where do I know this woman from? Well, I think it's finally coming back to me about right now. Hey, Greg, how are you?
I'm pretty good. Did you get lost?
Hello.
Hello.
How you doing?
I'm good. How are you?
I'm fine.
Where are we going?
I was going to ask you that question. Hey, good day, sir.
Good to see you.
Nice to see you.
Hi.
Hello. Hello, Doreen.
Hi, how are you, Don?
I'm fine. I'm your shuttle driver today.
You're my shuttle driver today. Good.
Where do you work here?
I work at Gilchrist.
What do you do?
I do Gilchrist Kids, their pediatric program.
Wow, I didn't realize they had a pediatric program.
Yeah, a big pediatric program.
Wow.
I chose Gilchrist because I like taking care of patients that are very ill and that needed help.
I love GBMC. I think it's a great place to be. I think the thing that's kept me here is that it really feels like a family.
Why GBMC?
We have an awesome clientele that comes here. Most of our patients are sick as they can be. They're always nice. They're always glad you've helped them.
We have fabulous community support.
Yeah, this big donor dinner coming.
Absolutely, and we have people that give of their time and of their resources, and we're so grateful for that. You know, GBMC is 51 years old, and volunteers from the community decided we needed a hospital here to help their neighbors, and here we are. Steely Dan is the official band of GBMC Healthcare, because I said so.
To sing a song together.
Okay, I can do that.
Okay.
You want me to pick a song?
Yeah, and you have a favorite song?
Yes, let's listen to one.
This is that ice cold Michelle fight for that white gold. This one for them hood girls, them good girls, straight masterpieces.
Words to I Will Survive.
Women to the left of me, women to the right.
Yeah.
I got that sunshine in my pocket, got that good soul in my feet, got that hot blood in my body, when it drops. Ooh,
We hear you're leaving, that's okay.
Stay up too late. Got nothing in my brain.
That's actually my key.
People say, ooh, ooh.
Here we go, Don.
All right, waiting for the chorus.
Don't believe me, just watch. Woo! Oi, oi, TNT. Oi, oi.
Words to Survive.
But if you have a change of heart, Ricky, don't lose that number.
Yes, yes. Town funk you up, uptown funk you up. Woo! Uptown funk you up, uptown funk you up. Can't stop the feel, can't stop the feeling. So just dance, dance, dance. So just dance, dance, dance. Watch it explode.
It's hard to drive with this one.
We really have to learn that song.
Yeah, well, how important are donors?
Yeah, donors are critical. We can't do what we do every day without the support of philanthropy.
We have the best domestic violence program that I know of. We have our safe nurses who are trained in sexual assault forensics. We don't come anywhere near covering the costs of those programs with billing. We get almost nothing from patient billing. The programs are totally supported by donors.
We got new beds in our ICU that are amazing in what they can do.
Gilchrist Hospice, I don't think would even exist without the donors. That's how we are funded.
GBMC thrives to this day because of the phenomenal community support we have.
I just love being able to be there for families and patients in that really critical situation when it's probably one of the hardest times that they're ever going to experience in their lives. I can kind of be there to help walk them through that.
Gilchrist was the best thing. I tell you, I wouldn't trade it for the world.
I love my job. I love waking up every morning. I love going to work.
We're looking forward to building some more patient-centered medical homes, and that takes money. And we are very, very grateful for our donors, because without the donors, we couldn't do so much of what we are already doing, let alone do the building we need to do for the future.
Thanks, buddy. See ya.
Thank you so much. I so appreciate it.
Nice to meet you. Have a great day.
Thanks, you too. That was fun.
It's been a great deal of
It
fun.
was fun. Thanks a lot, Don. Good to see you. Thanks
see
for the
you.
lift. And keep up those singing lessons. Don is a great driver. Not much of a singer, but he's a great driver.
My apologies to James Corden from CBS.
No way, it was great. I loved it.
And my everlasting thank you to you.
Are we gonna sing
for
again
taking
today?
part.
Will you
No.
please?
I don't think
I'll pay
so.
you.
Time is limited.
So is
Okay,
that Lean
true,
Daily
true.
Management?
Actually, I don't think there's been a better morale builder.
Yes, very true. Very true.
All right, so people are probably watching and probably thinking, what, that was a little out of the blue, right? But this is just kind of the way that GBMC shows how it is not only community-based, not only focused on superior healthcare, but they like to have fun. It's kind of a big family, and that's what it's all about.
And we should run down your titles before we go too far. She's nurse manager of MICU, SICU, and the central monitor room. And I think you got a big promotion after we did carpool
Yes, it was
karaoke.
right after that. Yeah.
So don't ever say no.
That's right.
Well, welcome, because as we all know, has anyone who's ever been in the hospital or who's ever had a loved one in the hospital, nurses hold the whole thing together, man. You guys are the glue. So thanks for all the work you do. You've got a great nurse. It makes the world a difference.
It's true.
And we're talking about some serious stuff
Yeah, lots
about
of
healthcare and hospitals.
initials
and-
coming up again today. Not just GBMC, but we're going to talk a lot about LDM. And LDM is
LDM stands for Lean Daily Management. So what Lean Daily Management is, it's a way that at GBMC that we're able to look at processes that we have. So, in the ICU, in the intensive care unit, there are a lot of things that are going on, a lot of moving pieces that all need to work together for this great symphony that we can take great care of our patients. So we need to look at those processes on a daily basis to say, what are we doing well? What can we improve upon? And Lean Daily Management is how we do that at GBMC in the ICUs.
So people hear the word LDM, Lean Daily Management, it all starts to seem kind of wonky, but it is the way that companies really manage what they do in the most efficient and safe manner possible. And I think it's very enlightened, and I'm not just saying this because I'm being a cheerleader for GBMC, but it's very enlightened that the management of GBMC went and looked at other companies and corporations to see what they were doing so well, and they were able to bring it in. And so it has this name, Lean Daily Management. You're like, what is that? But when you get to understand the whole term, as we all should, because we can play a role in it as well, it's super important. So LDM, just keep that in your mind for the rest of the hour.
And all the bosses of the hospital really do gather every morning at 9 o'clock. They walk by us on the volunteer desk out front, and I walk through the hospital going to different wards, and you're getting something from each ward, or if they call them wards anymore, and you do something with that information you get.
So every day in the ICUs and other units and departments in the hospital, our executive teams come to our units, and either I or one of my nurses present the boards to them. So what it looks like on our units is that we have 2 boards, and we have 4 metrics that have to do with those processes that we have on our unit, whether or not it's looking at a documentation or looking at a different checklist that we have, and we present that to them saying, this is how we're doing, this is what we're doing today. And if we miss that goal, it's not particularly that, oh, well, it's terrible that you missed it. Well, of course we want to make those goals, but it's, okay, how do we improve? How do we make changes to this process so that tomorrow we can make it and meet that goal?
When you say board, it's an actual
Yeah,
board?
Yeah, so it's an actual board. It's a large board that has different goals on it, and we present that on a daily basis.
Can you give an example of a goal?
Sure. So there are 2 that right now that we have on our boards, which are really interesting, and one of them has to do with nursing documentation. And I think right now, especially in nursing, we hear a lot about documentation, and so what we're looking at pain documentation. So when you, as the patient, are in pain, it's the nurse's responsibility to document that appropriately and give the correct medication. So we're looking at what is the best way for us to do it, and how can we do it well, and also streamline it so it's the most time efficient for nursing.
I would imagine, like, when you're a nurse and it's chaotic and you've got maybe the whole area that you're working in is full of patients, and then the management comes to you and says, we're going to have a new system here, and that's very stressful. But I'm wondering, and I know it's sort of a rhetorical question, but if in the end, once you learned all these new systems and it made your life easier and you were more open to these changes.
I will be the first to admit that when LDM first came to GBMC, I was a little skeptical, and I thought, how is this going to look? How is this going to be? And it really wasn't. It was when I started to see the positive change, and I saw that we were able to improve patient outcomes, and we were able to improve nursing workflow, and see, wow, this really does make a difference. And like you said, it makes everyone's life easier, and ultimately we have better patient outcomes because of it.
You're looking at it as a manager, though, taking part in LDM. What about the nurses who work under you? Do they say, oh, gosh, here they come again?
Well, I think they are able to really buy into it as well. They've seen the changes that our LDM process has made, and now they come to me and say, hey, Rachel, we need to put this up on the LDM board, or this is something that we need to look at. And that just makes me so happy, because that's the purpose.
So they're taking ownership rather than being judged.
Correct.
I think there's always a feeling when management comes down to watch what you're doing that you're going to be judged, and you're nervous about making a mistake. But instead, there's a buy-in across the board, so to speak, right?
Okay, we saw last hour that there's a thing called metrics. How do you pick first of all, what is a metric, and how do you pick it?
Sure. So the metrics are, like I said before, are looking at our process. So documentation, different checklists, and how can we improve those things. And for the ICUs, it is the staff who pick those things. And there are certain metrics that I might say, oh, this is a hospital-wide initiative, or this is something that we need to focus on. But they are the ones who say, this is what we need to do, and this is what we need to improve.
Can you run down just some of the big things that really changed over the course of time with LDM, what you've noticed, and how patient care really specifically improved?
So one way in the ICUs is that we initiated a checklist that was done at bedside handoff. So bedside handoff is when I, as the nurse, am leaving and I'm giving handoff to an oncoming nurse, and I'm telling about the patient, their diagnosis, what's going on, what will be going on. And what we found is that there are a few key safety issues that we needed to address at that time. So if the patient was a high fall risk, that we had all the fall interventions in place. So there were many different safety things that we need to make a checklist and say, these things are done and they're appropriate. And we actually saw a decrease in infection rates for our patients and other outcomes that were really beneficial. We actually were able to go to no infection rates related to our central line and Foley catheter. So great work that we were able to do with that.
I thought this was so interesting, too, is that the patient is included in that conversation. Correct. And can I ask, too, if the patient is not in a place where they can be included or in a position to be included, are the family members who might be sitting in the room included in the conversation?
Oh, most definitely. And that is so important, because if you as the patient are not able to participate in that, then your family are the ones who should be doing that.
And you feel like you're being worked on. I understand we have a question from the audience.
Yeah, actually, this one, there's two questions. One has to deal with patient bedside, and the other one has to do with pathogens. So I'll start with the bedside question first. Can you help explain why it is considered a restraint to keep both railings up in a hospital bed, even though the patient slips out of the bed and falls, which can be quite dangerous to the patient?
So I can speak from our perspective in the ICU. I don't know if you noticed in the video, but I had mentioned something about the ICU getting new beds. And the special beds that we got are wonderful. They do amazing things, even up to like turning patients so that people aren't getting bed sores. So it's really incredible, the things that are available. So for those specialty beds, us having all four side rails up is not considered a restraint because of all the mechanisms that it can do. So from the ICU perspective, that isn't a restraint. And there are other precautions that we can put in place to make sure that falls don't happen. There are many different alarms, other signage, other precautions that we can use to make sure that patients don't fall.
The other question has to do with pathogens. There is data that pathogens stay on curtains and bedclothes, causing infection. What is being done in regards to this problem is a question from Leslie.
I think it's a really great question.
That's a great question.
Yes, it's really, really good. So I can speak to our phenomenal housekeeping department at GBMC and say that we are really a team in making sure that our rooms are cleaned appropriately. Part of the safety check that I was talking about earlier is making sure that the room is clean. So is everything clean? Are the curtains clean? Is the trash taken out appropriately? Are the counters clean? So really, it needs to be a collaborative involvement with nursing as well as the housekeeping department to make sure that our rooms and hospitals are cleaned the way that they should.
While we're talking about pathogens and infection, I mean, it's a great time to talk about hand washing.
Yes.
Such a huge, such a simple thing and such a huge part of the healing process.
And what a great big emphasis is put on it at GBMC.
So we've heard, wash in, wash out, anyone who's been in the hospital. And so can you get real specific about it? Because I was thinking about my last time I was visiting someone in the hospital, and I remember the healthcare professionals, whoever they were, coming in and out, and they were mostly using the antibacterial gel. Does that count as washing in, washing out? So can you touch on all of that?
I love that you asked that.
And what we should look for.
Yes, because that is so important that you as the patient and family members are comfortable asking those questions. That when you see that's not happening, that you can say, hey, you didn't wash your hands. And that is something that is very important. So the hand gel is something that's appropriate for hand hygiene, unless your hands are visibly soiled. And then you would want to use soap and water. But the hand gel is appropriate for washing in and out.
So specifically, what should the wash in and wash out look like? And what doesn't qualify for doing it properly?
So it should be so what we say is that as soon as you cross that threshold in the room of the ICU, that you are either using the hand sanitizer or washing your hands. And it shouldn't be like a little
dip.
Barely, right, that's right, just walking by. It needs to be a thorough hand washing. And then as soon as you leave as well, or as soon as you're, like I said, if the hands are visibly soiled, that
You know
needs to
what?
happen
I'm going
as
to
well.
ask you to put your mic down.
Okay.
And show us the motion of your hands, because against your black dress, we're going to be able to see it.
Sure.
So how should it look?
Okay, so you want to make sure that you're rubbing your hands together like this. And one thing that I feel like we miss oftentimes is like the thumbs, making sure to get under the thumbs, rubbing your fingers on your palms like this, and have a thorough, making sure that all your surfaces are being touched.
We have a instructional video every year that the volunteers have to see. And my wife has seen me washing my hands after that. She says, "What are you doing?" The little fingertip thing. But it gets everything clean.
And I'm sure at first, like with anything, when you do something first, you think, I don't have time to do that.
Yes.
I have so many other things to think about. But once you do it over and over, it becomes second. Honestly, I was listening to the conversation prior, and I was like, where's the hand sanitizer? Like, I just felt this urge to wash my hands.
Yeah.
But you get used to it.
It's true. Yeah, and it just becomes a part of our daily routine.
And hand sanitizer won't do it alone. I mean, you really do have to wash in and wash out.
But no, they use the hand sanitizer.
You can
for
use
that.
the hand sanitizer.
You the gel, I've thought,
Right.
with the soap and stuff like that.
Yeah.
But, physically washing our hands we're supposed to do. And we're told that sometimes there are spies around watching to see who's washing their hands and who's isn't.
Quality control.
It's a great thing.
Keep
Or
everyone accountable.
LDM.
That's right.
So where would you like to see, I mean, because everyone has ideas, and you're taking now the nurses' ideas, and everyone's on board and wanting to participate and make a difference and feel relevant to what they're doing and the changes that can happen. What would you like to see LDM do next? Or what is the next frontier for you guys and your people?
I think that just continuing to look at what we do on a daily basis. I think that LDM has helped us to be able to look at what we do and say, I think sometimes we say, oh, we do this because we've always done it. And so when we can look at those processes and say, is this the best way to do it? Is this going to get us the best outcomes, or are we doing just this because we've always done it this way? And I think that we just need to continue to make those improvements. And there are going to be things that I find out tomorrow, problems that I don't know about today. And so we need to continue using this process of looking at this data and analyzing it on a daily basis to solve those future problems as well.
And I think there's one last question for you from the audience.
What about the issue of antibacterial soap causing resistant bacteria?
Great question.
As a nurse, I will say that anything that we can do to make things as clean as possible. I'm not an infectious disease doctor to be able to kind of give you the nitty gritty of what's going on with at the organism level, but I would say that we in the hospital are finding that we're just needing to clean things differently, and we're continually to improve how we clean things and how we are looking at making our hospitals the safest place for our patients to be.
Rachel, what is the biggest obstacle to kind of performing at this level? Is it fatigue among the staff?
I think it depends on the day sometimes. I think fatigue, I think the fact that there are so many things going on in any hospital environment, but especially in the ICU, there are so many different things going on, and it's, we're human, and sometimes we forget. And so how to get to the point where we have been able to almost mistake-proof ourselves and have those different levels so that if someone forgets, how do you catch that? And how do you get to the point where you can get through your day and follow your process correctly and still realize that you're a human and there are going to be times that you forget?
Thank you very much. Thank you.
Thanks, Rachel.
Thank
Nursing's
you.
come a long way, I bet, since you first started, right?
It's been a fun ride.
Yeah.
Yeah.
And more to come.
Thank you.
Rachel Ridgely, thank you so much.
And thank you for singing that. Day,
Yeah.
too. Yes.
My pleasure.
Look, I give you a lot of credit. I would have been a wreck.
Thank you
and
for
I
sing-
didn't hear you singing much.
Thank you singing.
actually.
I was going to thank her for singing loud because they kept my mic very low, and the other participants who could sing, their mics were up.
I just like to shout out to Greg Schaefer, who was the AC/DC
I
guy.
think his family's still
mean-
talking about that video. But
That was fantastic. Lisa, hello and welcome.
Nice to meet you.
Nice to meet you too, Lisa Griffee.
Lisa, go ahead.
Who's the Director of Quality Improvement.
Yes.
This is your topic of conversation, isn't it?
Yes, it is.
So, go ahead.
Well, you're part of the LDM parade every day.
I was going to say,
Okay.
we parade by you often, and you're seeing the start of the walk when we all leave the executive office, and then we divide into 5 different routes so that we can cover all different areas of the hospital. And I think you see us straggling back to all
Yes, to the
meet again at the
to the conference room. Well, what's your particular role in the LDM process?
So I started as the lean facilitator at the hospital. So I come from a performance improvement background. So teaching people how to establish their boards and their lean daily management boards, that's part of what I do, but also coaching the executives as well in what their role is.
You manage
as
up
part
and
of-
down, don't you?
Yes.
I bet you have a great household.
I don't know. That's up for debate.
You
but
leave it all at work.
Yes.
Can you just describe, I'm just trying to picture what the morning looks like. I mean, there's so many issues that executives and board members want to deal with, right? Other than doing the sort of the daily, I'm sure, right?
I think when they first, when the idea and Dr. Chassar first said, okay, we're going to do this, I think everybody was like, how are we going to find an hour every morning to break away from our very busy schedules and go visit all of these locations?
And do something different.
And do something different.
Now, so it's like, so you were like, I'll do maternity. I mean, what locations do you go to? Are there the big 5? Are there the...
Oh, that's a good question. I think, so you just had an example of Rachel talking about our clinical areas and the boards that they have up in the metrics that they're looking at. But the great thing about, I think, what LDM brought to the hospital is that we not just have kind of those patient-facing areas that we go to, but we also have support areas that we visit as well. So pharmacy, radiology, housekeeping, food nutrition, materials management. We go to all of it because all of that is so essential, and they all play a role in the flow and the operations of the hospital. So there's opportunity for all of them to kind of improve what we're doing.
So there's a rotating list.
There is, we visit the same departments every day. But
Wow.
Yeah, I know. But we divide them into 5 different groups, and then our executives are on a rotating. So every 2 weeks they switch the route that they're on, so that everybody gets to see all the executives. All the executives get to see all of the departments and what their boards have up on them and what metrics they're working on. Mm-hmm.
And some of the people who take part in the LDM rounds would surprise you, I think, because the foundation president is there.
Yes.
And not just hand-to-hand medicine.
Yeah, I think that was one of the really eye-opening things when we first started, is that the clinical directors certainly, I think, knew what to expect out in the front lines, and there may have been some skepticism from the foundation or from finance or other folks that don't typically get out there on the front line. But what all of them found is how meaningful it is to get outside of their office, outside of their boundaries, and really appreciate what's happening in all of the different departments and operations. And that was great in reverse as well for the clinically focused directors also and vice presidents to get out and see some of the support areas and how they're helping to support the overall workflow. I think it made everybody more educated.
I'm sure it did.
Yeah.
24 people walk by, and there's probably 4 in white coats. It's
and you think, who are those people? And I
so
bet
it's
at
not
first
medicine.
too, I bet at first they were like, oh, here they come. Here they come. Are you ready? Is everyone ready?
Well,
but now I imagine it's
a cultural change, and that always takes time, right? So yes, it was a little intimidating when we first started. Am I going to get yelled at if we're saying that we didn't meet our goal yesterday? And the beautiful thing is it's really created this trust between the executives and the frontline staff, that they're able to have this open dialogue about what's happening. And these boards, by the way, they're in very visible places. They're not like hidden in a break room somewhere where no one can see. I mean, they're
the
right,
mysterious board, right?
Yeah, they're right in the middle of the unit, so everybody can see what the metrics are that are being worked on. So yeah, that's been
a lot of times right close to a nurse's station, and
yes.
You'll see them talking amongst each other with a person from that particular department or whatever, but everybody else is standing around listening. So if it's going to be a dog and pony show that may not be the truth, it's going to show up.
Well, and it's broken down some of those barriers. I mean, I don't think there's a whole lot of organizations, especially in healthcare. I think one of the things that makes LDM special and unique to GBMC is that interaction that's happening between the frontline staff, and they get to know all of the senior staff. That doesn't happen at other hospitals.
I was going to ask you that, because this is a big healthcare oriented community.
Yes.
I mean, in general, the whole Baltimore area. And don't you just want to run around to the other hospitals and say, you guys should try this? I mean,
well, if I'm being honest, most of them have come and
to see it.
Yes,
okay,
and observe what we're doing and how we've absolutely, yeah.
Do you have your favorite tangible result of LDM? Something that stands out to you that happened because?
You talked earlier about winning the Ashram Award, and that was really patient safety focused. And I think the improvement that we did with a lot of the patient safety metrics is really meaningful and valuable. But I have to tell you,
award.
That
there you are.
Yeah. Oh, hi. Yes, that's the award. But I think for me personally, I really like just seeing how it empowers the staff to fix the things that are important to them. So one of the other things that makes this unique to our organization is that there's not some directive coming from on high down to somebody that says you need to measure this and make it better. The folks that are working in all of these departments, they are passionate about what's happening in their departments, and they know what there's energy and enthusiasm around focusing on. So it's really been this great tool that it's not just the managers, it's the frontline staff that are they have now a mechanism of how they can improve, not just patient safety, but customer experience, eliminate waste that's in their day, one of the big frustrations. We all are super busy, and anything that we can do to make that workflow better.
Sure,
and
like paperwork that's redundant.
Yeah, or searching for missing things, that should be there that are missing, and how do we create a system that doesn't happen again. But also there's a more joy metric that's on the board as well, and that's really focused on employee engagement. And so when the managers are coming up with new metrics, asking their staff, like, what's meaningful to you? What could we do better? What are you passionate about? Let's put that on the board as well. We're focused on the whole that whole experience, all of the quadruple aim that Dr. Sarr had mentioned earlier when he was here.
I imagine there's validation too for the people on the front lines that here this person in this office has a real sense for what I'm doing now.
Exactly. And to be able to get like a handshake, a high five from the president of the organization when you're there presenting the board and talking about the test of change that you might have done on one of the metrics, and then have been able to see with the data that it's made a difference, that it's improved, and to be able to get credit for that, and to really get a thank you from all of that, the executive staff that are circulating through. Yeah, I think that's powerful.
And to get something fixed. I think every large corporation, you have your inner complaints.
It's so big and unwieldy, it's very hard to fix
You talk
things
to your
sometimes.
coworker saying, well, blah, blah, we got to fix this, but this things get fixed.
Yes, and things that matter to the frontline staff get fixed, and I think that's super important.
So I would venture to guess that anyone who works at GBMC now knows what LDM means, or they've heard it, right? They get it.
Yeah, they get it.
Is there now a push to reach the community with that phraseology and let them know, because in a way they too can participate in LDM if they know what it is and what is happening. They have a greater understanding for what's buzzing around them while they're there.
I don't know that the push per se is to have them understand like LDM and what that necessarily means, but we are engaging the patients because some of the metrics that we're working on measuring, especially the ones around
safety,
or even their overall care experience, there's reports that we can look at, patient surveys that come back to us, a month and a half after the patient is discharged, and you're kind of guessing, I wonder what happened a month and a half ago to get that result on the survey. Well, this allows them that if they're focused on something, medication education, that they can test it in real time, going into the patient rooms, coming up with, well, what works? What's the information packet? What questions how do we present this to the patient? Redesigning a pamphlet and an educational pamphlet that they hand out so that we're learning in real time. And that really allows you to be way more nimble with making changes and understanding what their direct impact is.
I'm always big on semantics, and I go back to your title. You're the Director of Quality Improvement, where once upon a time I think that would have been called Quality Control. And
well, yeah, maybe. I mean,
I mean, it seems more
soft, friendly.
Yeah, I can be part of
less
this.
Intimidating.
Yeah, you're not controlling other people. You're all working together for improvement. I just noticed it was different. I would call it quality control. Has there always been a director of quality at GBMC?
There's always been a quality and patient safety department at GBMC.
Okay.
I think that the role of quality improvement is really kind of fusing all of the tools of how do you teach people how to do improvement and how to really tell if what they're trying to improve is working and having success. So, but we're also melding it with the quality side. So we are looking at our patient safety metrics. We are listening to patient grievances fall under, under this bucket. So we are listening to complaints and grievances and trying to resolve them. We are looking at, we have an incident reporting system so that anybody within the organization can report their concerns, or if something happens that shouldn't have happened, it's our way of, it's our system of investigating that and with the help of others. So all of that falls under, but maybe it's not control because it's not, I hope we're not using like, I don't know, when I hear quality control, I think of like big stick.
Sure, the whip.
You shouldn't do this. And instead, we're helping them think of look, nobody wants to make a mistake. Nobody comes into work trying to do something wrong. And if something happens that shouldn't happen, absolutely it impacts the patients and the family. It impacts the providers too, in all honesty. So this though gives them when something happens that shouldn't happen, we don't want to just, oh my gosh, that was horrible, and put a Band-Aid on it. We want to design a system that will prevent that from ever happening again for the next round. And that's the power in this, is really not looking at the people, not looking at blame, not not expecting Rachel and all of their nurses that fall under her to just, you should remember, why didn't you remember this, that, or the other thing, is really how do you design a system that's kind of helping people do the right thing and preventing them from making an error.
The other thing, and speaking of potentially making an error, the other thing that's very powerful about this, and I think you could have LDM without it actually, but is the transparency piece.
Yes.
And maybe it's just a sort of public relations or the way we've viewed hospitals over the years, but I think a lot of people really question whether hospitals are truly transparent. I think in a litigious society, we tend to fall back and think, oh, they're going to protect their own, they're going to protect themselves, it's about money, et cetera, et cetera. But I get the sense that with this transparency and making all these numbers and metrics open for everyone, you're trying to overcome that sort of perception.
Yeah, and we're also trying to get their feedback in how we design those systems better.
It removes the fear piece.
I think so. Yeah, I really believe so. And listen, when you're talking about transparency, or there was some earlier discussion about disclosure, and a person had a question about that. We have processes in place for that disclosure and how we handle that, and it is transparent. But you know what people want to hear? People want to hear that you're going to do something about it, like that no one ever has to experience that again. And that's where these improvement tools provide value, because we're giving that set of skills to the frontline staff to really look at the systems differently and think about, how could we make sure that never happens?
Okay, we have an audience question or two.
Yes, we do. Do you ever have staff, not the management, go from one department to visit another department to experience the challenges and difficulties in their worlds to get a better understanding of overall operations?
For the LDM walk and that visit, we do have staff that comes along. So sometimes that parade that passes you, Don, is a little larger because we're including other people so that they have a chance to experience what others are measuring and what they're learning and what they're focused on. So we try to incorporate that. Once people get really great, though, with problem solving, we do metrics that are two departments really working with each other. And that only works when, both of them are committed to having that dialogue on a daily basis and working on a systems issue. So I think Dr. Chassar mentioned missing meds. Well, that's a pharmacy working directly with another manager to every single day be curious about what happened, what could we have done to prevent that, what should we try new? Let's go ahead and try it and see if it makes a difference.
I think the question was going after, do you take somebody from maternity and show them what happens at ICU or vice versa? Does that happen?
As far as for improvement skills, yes, but I don't know. Shared day, Rachel, do we do that for share time?
Appreciation of what other departments do.
Yeah, just so you know what somebody else is doing down the hall.
Yeah. So my nurse friend Rachel is over here shaking her head saying, yes, Lisa, our nurses do that.
How many departments are there?
On LDM in the hospital proper, we visit 35 different locations.
Wow.
But as a system, in an hour. But as a system of GBMC is that we've also taken this tool and brought it to Gilchrist.
I was just gonna ask you that.
And we've also brought it to all of our GBMC health partners. Both the primary care and specialty practices are also using this same tool. Because they're located all over the place, it doesn't make it conducive for a walk or a 1 hour visit. But the way that they handle that in those locations is they still have a daily huddle with the staff at the board, but then once a week, there's a subset of administrators that get in a car and go and visit them so that they still have that interaction between the front line and the executive staff.
And still feel part of a bigger thing.
Absolutely.
Yeah.
Yeah. Do you think that this is one of the beautiful things about having a community hospital as opposed to a huge, enormous corporate entity?
Yes, and I hear that actually all the time from people that come and visit us that are like, I don't know how
I wish we could do this.
Yeah, or I wish we could do this, or I have no idea how we would do this. Of course, I never see the president. They're located in some far distant place, and I'm not even sure I know that person's name. But that is a blessing in being a community hospital, is that we are kind of knocking down those barriers with, the executives here in the front line here. They're getting to know each other by name. We're working collaboratively on problem solving, and we're also a little more nimble. There's not as much. I don't know. There's
bureaucracy,
not as many
red tape,
exactly.
geographic issues, all that kind of stuff.
Correct.
But, and I think you guys ask why not more often.
Yeah.
Why can't we do it this way? Why can't we get better?
Or why can't we try?
Yeah.
Like, let's try it.
I'm wondering, is
See if it works.
LDM a set process, or can it in and of itself change?
Are you?
That's a wonky question.
That
So in
was-
other words, you're borrowing this LDM thing that was established by Toyota, Boeing,
yeah.
companies. You're taking it and incorporating it into healthcare, which you obviously had to tweak for your.
We did. Yes.
But is it good the way it is, or can you change the actual?
Well, I'm an improvement person.
So you're going to improve everything. Everything gets improved.
So everything always has an opportunity to constantly be refined and improved. And believe me, I was listening closely when you asked Rachel the question of, what would she like to see as the evolution of LDM. We're always looking for what could we do different, or what new tools can we help bring to the team to help them be successful in their problem solving.
How about one thing we didn't ask, and I know you're probably, Rachel, more. Oh no, you are too. But how about feedback, like positive reinforcement to the staff based on this process?
That was part of the. I think two interesting things when our executives engaged in this is what's their role at the LDM board, and their role is to inspire and connect kind of the work that's being done to the vision. Their work is to say thank you for for what people are trying, and we've got to remember to thank people even when they try to do a test of change that doesn't work, because they're still learning. They're getting more educated on, okay, now what's the next test? Because I think we're probably gonna be more successful in that next iteration. And they're also there to remove barriers. So that's part of the dialogue and the exchange that goes back and forth of if something's broken, if they're having a hard time kind of getting it fixed, having that direct pipeline to the executive staff, boy, that's powerful in getting what you need and the tools that you need to get your job done that day. But the one thing we don't want the executive team to do is to get caught up in telling people what to do to fix the problem, because that doesn't help people learn how to do their own problem solving. So it's an interesting balance, and I think that's part of always the fine tuning and the feedback loop, and we coach each other in what works and what doesn't work.
And I should point out that there's the three of us volunteers at the front desk all the time, and when the LDM parade goes by, they always thank us.
Yeah.
And
that goes a long way, doesn't it?
It feels
it's a
good.
simple
Yeah.
thing, but yeah.
It really does feel good.
Mm-hmm.
I was wondering too, I would imagine that when you tell people what you do, particularly, I don't know, I'm going to just say it at a party, but probably never happens at a party, but and someone says, oh, I had an issue, or this happened to me in a hospital, and right?
Yeah.
Like they want to tell you their story.
Absolutely.
And I bet you everyone in this room has some story that maybe didn't affect them, but affects someone they know or a loved one. And they never did anything about it, and it made them angry. What is the pipeline? How can a patient, a family of a patient, talk back to you guys, or let you guys know what happened or what is happening? What's the best avenue for that?
Well, first and foremost, like while they're in the midst of the experience, ask questions, be an advocate. If they don't understand anything, or something seems wrong, like call it out.
So
and
hard
ask.
sometimes.
It is hard.
So
it
hard.
is. So the second thing would be, we do have I'll call it a listening post, which is, places for people to make complaints or to call. If you want to call the quality team, you can call the quality team and get them involved. Quite often, if you have a complaint at the local level, though, I've got to tell you, like, the manager is usually able to swoop right in and resolve it. If you wait till after you leave, it's good knowledge, and we can certainly do some improvement based on that, but we couldn't impact
But you're
what was happening
receptive
at
to
the
hearing
time.
about it.
Oh my goodness, yes.
Because sometimes it is after the fact.
Yes.
It's the looking back.
Mm-hmm.
You know,
Sure.
right?
Yeah.
Where you're like,
I could have.
we
I
should have
should've.
said, or if only this didn't happen, right?
I've done that myself,
Right.
You know, in
life,
seeking,
right.
in life, or even in seeking care. Like, why did I advocate more strongly for
Right.
what when it was happening at the time? But the other thing that we have is we also involve patients and family members from the community directly. So
Are
we
those
have
the next initials on our notes there?
PFAC, patient
yeah,
family.
PFAC.
More letters. PFAC.
PFAC. It's our Patient Family Advisory Council, and we ask for patient family advisors to kind of come in and give us their advice. So one of the things that we did when we first started this council 2 years ago was ask when we were interviewing people that were interested, or when people gave us referrals for those that thought would be a really valuable resource, is, what's gone well at GBMC, but you got to be willing to tell us what isn't going well, and you got to, help us. Like, we want to improve. Now, this meeting that happens once every other month, it is like, they probably need to start thinking about having it every month, because the executives want to come to this meeting. Everybody that's got a project or a big initiative, they want to hear what our patient family advisors have to say, because it's such a valuable voice. I think sometimes in healthcare,
Absolutely.
we kind of get caught up with, well, I seek healthcare too, so I can speak from the perspective of a patient, but I don't know. Our perspective is different when you're in it. You really need to talk to people that are outside of it to get a more objective opinion in what they think. One of the things that just came to our PFAC meeting was the ED. So our ED nurses came and they're talking
Emergency
about.
department.
Thank you. Oh, thank you, Don. They came to the meeting. Kind of, they'd come up with this little guidebook that they were really proud of themselves and thought this is going to make people understand what's happening in the emergency department so clear. And then they asked the advisors, and the advisors gave lots of really wonderful, frank feedback. And that's great, because then we can get it better before we roll it out.
Yeah.
Yeah, it is a focus group. But we also have patients and families that sit on other committees. So we have a grievance committee. We have patient family advisors on that one. They are involved in our board quality council. So they come to those meetings. We try to kind of always remember to get that outside perspective, and when we think we're onto something, it's a good litmus test to ask for their advice.
What else comes up at the PFAC meetings?
Well, gosh, so many things. So sometimes it's really just the airing of grievances, not so
sure.
much,
Yeah.
but hey, or a family member just had this experience. How can we fix this? Oftentimes now, people are proactively bringing, before you spend a lot of money redesigning a center, maybe we should ask patients, will this meet your needs?
Okay, yeah.
Instead of,
Wow, that's novel.
Yeah, right? So we're involving them in any type of design work, any process engineering, if we're really thinking about doing something different, that there's opportunities to bring patients into that work.
Okay.
The single biggest issue when it comes to patient safety in your mind, which is a constant battle that you have to stay vigilant on.
I think, listen, I'll go back to, I don't think, first off, patients kind of speaking up and using their voice, but from the provider side, use the tools that we have. There's lots of tools to improve it. Don't accept that this is, you're coming into a hospital, a certain percentage of people are just they're going to get an infection.
That's what we think. But that is what we think.
That was
they're trying to get me out of here as soon as possible so I don't get an infection.
Yeah.
That is what the general population believes,
and that,
I think.
Well, because I think, I don't think, I know a long time ago it was acceptable. I mean, healthcare in general was just, yep, that's going to happen to a certain percentage of the population, and we'll just accept that. And now the thinking has changed dramatically, probably in the last 15 years, in saying, no, we can do better. There's no reason we should accept infections being part of an experience that the patient has. We need to do better. We need to be vigilant in designing systems that prevent that from happening. And I think we're being successful in that. I think we're making everybody think differently about the way that we care for the patients when they're here.
And if you're looking at an elective surgery, you're a consumer in many ways, and I think it's kind of the onus maybe is on us too to really look into different hospitals and find out what their policies are and what their metrics are and who's sharing the information before we make a choice.
Yep, go to Hospital Compare, but that's really old. Go to GBMC's website, and that gives you lots of data about quality issues, including infection rates, that type of thing.
And talk to others who've been in the hospital recently and ask questions.
Ask questions.
All right, Lisa Griffee, LDM, I'm going to take it home and use it in some fashion. I'm not sure. And also, the next time I'm in a hospital,
it's going to be a small parade around your
I'm going to be
house.
like, all right, kids, wash in and wash out. Everybody, right now.
That would be a good one to take home right there.
All right, and thanks all of you for joining us, and thanks to our big studio audience today. It's a great conversation and one we should all be having.
We got to get some initials going. LDM, PFAC, this is...
Right.
Like a little glossary.
Right.
Scroll
MBM,
underneath.
DS.
Yes.
Yeah, I like that.
And let me put in my pitch for Carpool Karaoke Part 2. I want to be in the carpool
All
next time.
right. All right. What's your song?
I'll think of it.
Okay.
I'll think of it.
All right.
You think of it in advance because
Oh, yeah.
we still don't know the words to I Will Survive.
We're glad you survived Greater Living today. And we'll be back in a month. So have a great day.
See you then. Thank you very much.